Good evening, everyone. My name is Jim, and tonight we have Dr. David Smith with us. He is an MIT-trained engineer who did his medical training at the University of Chicago. He has been a practicing physician for over 30 years. He is an orthopedic surgeon with Bone and Joint Physicians. They have multiple locations with offices in Oaklawn, Orland Park, Homewood, and Calumet City. As we go through the presentation, if you think of any questions, please type them into the webinar panel, and we will go through them once the presentation is done.
Well, Merry Christmas to everyone, and maybe Santa will bring us all painless knees. But for those who don't get that, we're going to talk tonight about knee problems that I commonly have seen in the office and how we approach those problems. I'd like to start out with this title, Total Knee Replacement is Not the Total Answer. I think so often I see patients who've been told they have arthritis, and I sometimes get the impression that they feel that it's just a matter of living with it, enduring the pain and limitations, or having a knee replacement. And there's a lot of things in between, and I think even when it comes to knee replacement, there's several options. So we're going to talk about knee pain causes, treatment, and options that are available to you. And the common problems that I see folks coming in with, they have pain, instability, in other words, the knee doesn't seem like it's stable enough that it can give out on them, and then stiffness. All those are very limiting in everyday life. This is something that I often say to patients when I see them in the office. Some years ago, when I was first starting out in practice, I read an article in the paper about what people didn't like about doctors, and as I often say, it was a rather lengthy list, but the main complaint was we just didn't communicate very well. So the people doing that study, they went back and asked those people, what was it you wanted to know when you saw the doctor? And basically it boiled down to these three questions. What's wrong? What can you do about it? And how can it turn out? In other words, what's your diagnosis? And this is a key thing. So often I see folks and they come in wanting to know if they should have this procedure or that procedure, but when I ask them what they think the underlying problem is, they don't seem to have an understanding of it. So we want to try and clarify that. And I think the more you understand that, the more it helps you making the right decision. And in the second issue, in other words, what can you do about it? What are the treatments? And then how it can turn out. In other words, what's the chance of success? What's the chance of a complication? So I often use Sherlock Holmes, a fictional character created actually by a doctor who the detective really was taken from a real doctor that he knew in Scotland that was excellent at diagnosis. And he could look at the calluses on your hand and tell you what kind of work you did. And so this is an important part of being a physician, is in other words, studying the information and coming up with the diagnosis. So all great detectives have to gather information. And the fundamental things that we use, patient history, they used to tell us in medical school that if we listened long enough, the patient would give us the diagnosis. And I think to a large extent that's true. A physical examination, in other words, you got to lay hands on the knee, and despite all the expensive and fancy tests, still physical examination really confirms whether the things we're seeing on the test are really the problem. Because a lot of times there are tests that you can do, x-rays, ultrasound, MRI, that if you did them on someone who really wasn't having any problem with their knee, and let's say the person's over 50 or 60, there's a good chance you're going to find some abnormalities. And so the take-home message there is just because a test is abnormal doesn't necessarily mean that's a problem, unless it correlates with the physical and the history. X-rays, first test we talk about. Many times I have patients come in and they've already had X-rays, but when I look at the X-rays, I can see they weren't weight-bearing films. In other words, the person was laying down when the films were taken. And of course, a lot of knee problems really are aggravated when you stand up and when you bear weight. So we can see in some knees a pretty good joint space, this gap here between the bones. It's sort of like measuring the tread on a tire. And if you've got a situation like this where you've got complete loss of that joint space, that's an important thing to know. And if you don't get a weight-bearing film, you might miss that. It might look better than it really is. Some patients can't have MRIs. They have pacemakers or other devices that don't allow them to have the more advanced testing, such as an MRI. Ultrasound can be very effective. We use it in the office for injections, and a lot of times we can check ligaments, we can check tendons with it. It's just a sound wave test, very simple to do. This one is basically showing where the femur and the tibia come together. This structure, the meniscus we'll be talking about. This little dark line here shows a tear. So we can recognize that sometimes when a person can't have an MRI. And of course, this is the more expensive test, but it shows us a lot more. And compared to the x-ray where we just saw the bone, we can see other structures. Where muscle connects to bone, that's called a tendon. Where ligaments connect bone to bone, that's a ligament. And there's structures in the knee that are important to look at. One is the amount of cartilage. We see this gray area here at the end of the bone. That's really the tread on the tires, and the healthier the knee is, the better the cartilage is. The meniscus is sort of the carpeting that nature lays down to protect the cartilage, and it's a type of cartilage. It's called fibrocartilage. Sometimes it gets confusing. A lot of us remember the days when they talked about people having torn cartilage, and nowadays the actual structure known as the meniscus is a more accurate term. But it's still referring to the same thing, the tearing of this structure. So let's look at anatomy. If anyone's interested in history of science, it's a book I read some years ago about a famous anatomist who lived in the 1700s in England. And he learned a great deal about medicine just by studying human anatomy. And we're going to use that same approach. In other words, we're going to look at the structure of the knee. And it's sort of like if you looked at a car, if you lifted the hood and started pointing to things and asking the mechanic, what is that, what is that? You know, if you pointed to the alternators, what happens if the alternator goes out and you lose the electric charge to your battery? So when we look at the knee, basically 4 bones come together: the thigh bone or femur, the patella or kneecap, the tibia or shin bone, and the fibula, this small bone out to the side. The major weight bearing goes from femur to tibia. And for that to occur in a painless fashion, you need healthy cartilage, this white material we often refer to as the tread on the tires. And it's helpful to have a normal, healthy meniscus, this additional padding that gives some security and keeps the pressure down in the bone. And then you need healthy ligaments so the knee will be stable. It doesn't pop in or out of place. There's 4 major ligaments. The ones on the outside are called collateral ligaments. We call the big toe side of the knee medial. You'll often hear that word. And lateral is the outside or little toe side. So you might think of L for little and lateral. And there's these cross ligaments, the cruciates. So those are important to a healthy functioning joint. So we're going to look in greater detail how disease or abnormalities or injury to these various structures can explain the pain that you might be having. Help us to do the detective work. But like any great detective, if you watch all these crime shows on TV like I do, a lot of times you'll start to think of the suspects. In other words, you'll go, well, I think this guy did it, or if he didn't do it, this other guy did. And medicine's a little bit the same way. When a person comes in, when I go in the room and I start listening to them as they talk, I start thinking of these structures as possible bad guys and causing the pain. A torn meniscus, that pad that we were looking at on the anatomy, the ligaments that are the ropes you might think of that join bone to bone, arthritis, probably the thing we're going to talk the most about tonight, which is very high prevalence of this in folks over the age of 60. We start to see it in the late 40s, early 50s, and then finally in the 60s, you'll hear different numbers quoted, whether it's 20 or 30% of people over 60, if they got an x-ray, if they got an MRI, you would see some amount of arthritis. Even though some of those people may not be experiencing pain at the time, it does show an aging, often associated with arthritis. Loose bodies, this oftentimes is related to the arthritis as the cartilage fragments wear out. Sometimes pieces of cartilage and bone break off and they go into the joint, and they can get trapped in the joint and cause sudden pain and can cause you to not be able to straighten or bend your knee. Synovitis, that's the lining of the knee, the covering that produces the lubricant synovial fluid that's important to a healthy joint. So these are the structures, the meniscus, the ligaments, the good cartilage, absence of loose bodies, and a normal lining that produce a healthy, happy knee. So what is arthritis? And I think there's a lot of misunderstanding. People often talk to me after, let's say when I've done an arthroscopic surgery, they'll ask me, did I remove the arthritis? And in a sense, you really, no more than you could go to a Firestone dealer and ask them to take the wear off your tires. We can't take the arthritis out of the knee. We can deal with some of the mechanical problems and hopefully some of the cellular problems through medicines to reduce the cause of the pain. So the most common type we see is that wear and tear type of arthritis, referred to as osteoarthritis or degenerative joint disease. And this can often involve inflammation of the joint, that redness that you see in someone's eye that's got some sand or dirt particles. You'll see the blood vessels. When we scope knees, we see that type of inflammation inside the joint. Cartilage loss, that white stuff that coats the end of the bone that we keep referring to as the tread on the tires, that really helps distribute the force across the bones so we don't have localized areas of high pressure on the bone, because as we'll see in the future, bone pain is a significant part of arthritis. So I think it's important to think about these two general categories of pain generators, inflammation and mechanical problems. And why is that important? Because some of the treatments that you get, cortisone injections or anti-inflammatory pills such as Motrin, Advil, or Aleve, they're directed at inflammation. So if 80% of your problem is inflammation and you take an effective anti-inflammatory, either injection or pill, then perhaps you'll improve 80%. However, if you have a mechanical problem, and when I think of mechanical problems, I think of having a shoe where maybe a nail's coming through and it's irritating your foot. Well, no matter what pill you take, that's going to hurt until you deal with that mechanical problem. So mechanical problems in the knee are often arthritis induced, such as tears of the meniscus or loose bodies. This is an anatomy picture of an actual knee that's with the skin removed. We can see the patella here, you see the patellar tendon, but the important structure is the joint capsule. It's really important to understand this, both in terms of maintaining a healthy joint. When I see patients that have arthritis, if it was the same amount of arthritis, you might judge it based on an x-ray to be equal. One person can often do better than the other if they've maintained that flexibility of that capsule, as we were showing here. It's a thin, loose fitting, almost like wearing a t-shirt compared to wearing a stiff leather jacket. The stiff leather jacket occurs when a person allows that joint to get stiff from disuse and doesn't keep it stretched out, or they've had chronic inflammation that's been untreated. So we'll keep referring to that. Our next little slide here will show you some of the pathology or the process that goes on inside. If we look here to the left, we see what's considered the normal schematic drawing. We see the structures of the bone, this white area, again, that tread on the tires, the articular cartilage. We see the synovial fluid that is created by the lining of the joint. And then we see the bone. Each one of these structures can be involved in the arthritic process of someone who has a painful knee. If we look on the other side, if you look at that light green area, that's the capsule. And you see it went from a very thin, pliable area to a very thick, contracted area. And that's the sort of thing that you want to try and avoid, because once it occurs, it's very difficult to go from this to that. And even patients who have joint replacement, if they still have a thick, stiff capsule, they're not going to do as well as a person who has maintained good flexibility. That's one of the things we depend on our physical therapists to work with you on if you are starting to get arthritis, to make sure you understand how to do the stretching exercises to keep that capsule stretched out. Cartilage, this white material, when you start to get arthritis, that in a way is the fundamental process. These little fragments can come loose in the joint. They can become embedded in the synovium, and you can see over here there was a nice thin synovium that was producing lubrication. Those particles become embedded. You get over growth of that, and that can damage the capsule further. It can also erode the bone and erode the cartilage more. Then you see these changes, subcondylar. What's that mean? Sub meaning under, condylar meaning cartilage. So this part of the bone that's directly underneath the cartilage is a very important structure. And we're learning more and more about the role that the bone plays in creating pain. There's been studies done trying to look at what are the primary causes of pain. Well, when you look at the articular cartilage, that tread on the tires, it really has no pain fibers. You can stick a needle in it and it wouldn't hurt. So why does loss of cartilage create a problem? Because it shifts that force down to the bone, and the breakdown of that cartilage irritates the synovium, which is the lining of the joint. So the synovium has pain fibers, but it has more baroreceptors. And that's one of the interesting things as to why, people used to think, oh, that was an old wives' tale that weather changes made a difference. But we know now that changes in pressure do get detected in the joint through the synovium. Ligaments, we're talking about, they provide stability to the joint, but they also provide information back to the brain about the position of your knee, and that's very important. Great athletes have great perception, body control. When you think of those glory days of the Bulls, when we used to watch Michael Jordan jump, and he'd be up in the air doing several things before he landed. And of course, he was very gifted that way. But all of us have some information or feedback we get from our ligaments. But bone has the most pain fibers. That's why a broken bone is very painful. But that marrow edema, and this is something we're going to hear more and more about, that occurs because the cartilage has worn down, the body responds to the higher pressure, and this is something that we can see on MRIs. You don't see it as much on the X-ray, but you can see it very early, and we'll see changes in the color of the bone on the MRI that tells us this bone marrow edema is occurring. They've looked at specimens where this bone marrow edema has occurred underneath the microscope, and they see what are little fractures that occur within these little, what's called trabeculi within the bone. And we think those don't heal, and that produces pain. In other words, sort of what would be a non-union or a non-healing fracture. How do we know this information? How do we know what hurts and what doesn't? Well, there's a lot of experiments that have been done. We know that we inject lidocaine, a numbing medicine, into a joint with painful osteoarthritis. For most people, it doesn't give complete relief of the joint. This has led to some new and I think rather exciting things, and we'll see how it pans out in the future. But for some people who have localized marrow edema, the injection of this biologic bone cement may hold some promise, and that's something I think will hold for coming attractions in the future, but it is a promising area. It's being done now. There's a company named Zimmer, has a product called AccuFell. This is injected into the bone under anesthesia, oftentimes combined with arthroscopy, and it does seem to offer some hope of providing support to reduce some of that pain through supporting the weakened bone. So what is osteoarthritis, or OA, as you'll often hear? You'll hear the expression degenerative joint disease. It's that wear and tear arthritis that becomes more prevalent in each individual with every decade of life. So we see it, there's a high, if you took 100 people at random who were 40, and then 100 that were 50 and 60, as you go up within decades of life, the frequency of arthritis will go up. And this is different than rheumatoid arthritis, which is a different type of arthritis we're not going to talk about much tonight. But this is the most common. Rheumatoid arthritis is a small percentage, a very important disease. But in the 30-some years I've been in practice, the most progress really has been made in the management of rheumatoid arthritis. So that's a very hopeful sign. There are many, many new drugs and injections that really help those patients to diminish the overgrowth of the synovium that occurs in rheumatoid. But in osteoarthritis, we lump it as sort of a wear process, and it's probably a combination of different cellular processes. But what happens? The joint lining becomes thickened, pitted, and eroded, and painful. There's what we call bone spurs or osteophytes that form around the joint. These are a sign of loss of cartilage and the bones starting to respond. And the common activities of everyday life become painful. It's interesting. There's a combination of things. One thing I found in medicine is you can't jump to a conclusion too soon. In other words, if you see an x-ray and someone has no arthritis, they can still have a very painful knee. There are other things that can be occurring. There can be a torn meniscus. You can see arthritis and no pain. Oftentimes we'll see people that come in, let's say for the right knee, and when we're getting standing x-rays, we'll get both knees, and you'll see that it exists pretty equally based on the x-ray in both knees, but only one knee hurts. So we know there's many things going on that cause an arthritic joint to be painful. That also gives us hope that perhaps you could have an arthritic joint and render it painless if you can get the inflammation diminished. Pain and arthritis. Again, I see patients every day who have significant arthritis, but you get an MRI and you find out they have a meniscal tear, and it may be that non-arthritic problem could be the cause of the pain. And of course, we see a lot of people that have arthritis and have arthritic pain. So we've talked a lot about diagnosis, the various structures, and what can go wrong. The next question we said we were going to answer. As we started out, there were 3 questions we want to answer for patients. What's wrong? What can you do about it? How's it going to turn out? Hamlet had something to say. There are more things in heaven and earth than dreamt of in your philosophy, talking to his friend there. But my grandmother had a simpler way of saying it. There's more than one way to skin a cat. And I've tried to keep those wise words in mind as a doctor. And some years ago, I decided that I needed some way to keep an open mind and consider all possibilities of treatment when I saw a patient. So I found that the 5 fingers methodology was a good little reminder for me. In other words, there was physical therapy, medications, injections, bracing, and surgery. So let's go through those and how they are used in treating a knee problem. This is one thing a professor told me some years ago. He goes, David, a stiff knee is a painful knee. And I found those words to be pretty true. So sometimes we can help a patient just by trying to restore that motion. And because if you walk around with your knee flexed or not straight, it's very painful. I mean, if you were playing a game where you were walking around with both knees flexed, after a while you'd say, can I stand up straight? Because it's very tiring and it's very painful. We have a knee osteoarthritis school in our physical therapy, and the idea is to teach patients self-management, techniques of how to maintain a healthy joint. You can't change the genetic profile that you were given. In other words, if you come from a family where arthritis has plagued your mother, your grandparents, your brothers, your sisters, there's a reasonable chance that you may also develop arthritis. You can't change that, but you can change how you respond to it and not let the arthritis win any more battles than you have to give up. So if you go to therapy and you have to get a note from your physician, it's a good chance to get a complete evaluation of the therapeutic non-surgical treatments that are available to you. Every day I'm in the office, I see patients that I'll send them to therapy. We often do a thing called prehab. If I see someone and they want a total joint and we've decided that's the only thing left to do, I'll often send them to therapy to make sure that they're going to be able to cooperate with the therapy program after the total knee. Because if you do a total knee and you have a stiff capsule and you don't have someone who can really work after the operation to work through their range of motion, they're not going to get the same benefit as someone who's ready to do that. These are the important things. The ability to straighten your knee out is key. That's the first thing. We use this Shelbourne program as a well-known knee surgeon down in Indianapolis. And he came up with these principles, and I found it's very helpful. First, you got to get the knee so it straightens out, and there's a variety of ways that patients can learn how to do that themselves. Flexion, bending the knee, how far you can bend it. To go up and down stairs, you need at least 105 degrees of flexion to be able to do that without a lot of difficulty. And then the final thing we work on is strength. Two types of strength. One is the strength to lift a weight, but the other is endurance, to be able to continue to do an activity over a prolonged period of time. And life is a little more about endurance most times than any one big forceful contracture. It's the ability to walk and have the energy to continue to do our daily activities. So they work on what's called gait, which is basically a fancy way of saying walking. They work on posture. They work on getting those knees straight, getting them flexed and bending. They also look at any additional adaptations. You really need to look at the hip, the whole, what we call a kinetic chain. You need to look at the hip, the knee, and the foot and ankle. They all interrelate to each other. The old song about the knee bone's connected to the hip bone. A little bit of truth in that. Orthotics can be very important. I see a lot of people that have malalignment of their ankles. That causes a shifting of the force on the knees. We see a lot of patients who can benefit from some type of bracing program, and therapists are really helpful in helping us pick the appropriate exercise programs as well as the bracing. Medications. So that's the second finger here, and there's a variety of different types. There's the things you get at the drugstore, Motrin, Advil, Aleve, all the way up to the really fancy newer ones like Celebrex. These come under the category of what are called NSAIDs, non-steroidal anti-inflammatory drugs. They're certainly very helpful for a lot of people, but they need to be managed carefully. They can affect your GI tract, your intestines, your stomach, your lower intestines. People can get ulcers. They can affect your kidneys. When I see diabetic patients, we want to be very careful about them taking too many anti-inflammatories. Once you're past the age of 60, your kidney function, well, it certainly can be adequate, but it's not what it was when you were 40. And if you take too many of the anti-inflammatories, you could really tilt yourself in the direction of kidney failure. So you have to be careful with them. Just because you don't need a prescription to pick something up doesn't mean it's perfectly safe. Now here's some other things that people often ask about: chondroitin sulfate glucosamine. It's been widely studied. There's two things the FDA looks at. One is safety and the other is effectiveness. The safety of glucosamine DS is very good. It's benign in that sense. Its effectiveness, it's a low-level anti-inflammatory, but if it works for you, I think it's a reasonable thing to do. The pill is rather large. I talked to an internist once who told me that you take it with applesauce. It's much easier to swallow, and she was right. These things are a little hard to take down with water. But they don't regrow cartilage. I know a lot of times the ads and the things people tell you about chondroitin sulfate glucosamine lead people to think it's regrowing cartilage. It really doesn't. It just basically is an anti-inflammatory. So NSAIDs, big category. Something new for many years, diclofenac, Voltaren, is a pill that we've prescribed for arthritis. This is a newer thing that's come out in the past several years. It's a gel that you rub over the area of pain in the knee, and it will penetrate past the skin, can get into the soft tissue, and can be effective for some local areas of inflammation. What I like about it is you're not getting the systemic absorption. You know, when you take a pill, it goes everywhere in your body, and truthfully, you only want it to go to your knee. So this is something hopefully we'll see more of in the future. So chondroitin sulfate, safe thing to do. Effectiveness is somewhat in question. Injections. Now there's three types of injections. There's cortisone, there's a thing called viscosupplementation, and there's something called PRP. How do these differ? You heard a lot about cortisone with athletes and saying it damaged their knee, and I think those stories are a little overdone. I think the fact that a person tore their ligaments and tore their meniscus and used the cortisone on a regular basis so they could go play a sport, was an abuse of the medication, but taking it for a patient who has advanced arthritis, who may be looking at surgical treatment, is trying to delay that, I think cortisone is excellent. I think in many ways the cortisone injections are safer than taking the pills. But it's just something to discuss with your physician. Viscosupplementation is available in several different brands: Suparts, Synvisc, Orthovisc, Halligan. Basically, it's a chemical, hyaluronic acid or hyaluronate, that was found to be deficient in the fluid of arthritic joints. And this was about 20 years ago. They did a study in England. They found that it could isolate this chemical from chickens. So you'll often hear about chicken products. Now they have some cellular ways to extract it. It's usually a series of injections, one injection a week for either 3 weeks or 5 weeks. And there are some formulations that it's a one-time injection. But it's something you can discuss with your orthopedic surgeon or your rheumatologist. It's FDA approved. The Medicare approves it for use every 6 months. And a lot of patients get it once a year. Basically, it helps with lubrication. Again, it doesn't inflate the joint. It's not necessarily what I'd call a cushion. It's just a lubricant. But it can be very effective. Helps a lot of patients. I've been using it for about 15 years, and I've been satisfied that it's certainly a very effective treatment. PRP. A lot of times with athletes, these high-profile folks will see that they're trying different treatments, and then they're endorsing them. And the jury is still out on this, but basically, when we look at our blood, there's several products. There's red blood cells that carry oxygen, white blood cells that fight infection, and then there's platelets, which are cells that carry little packages of chemicals that are effective in healing. So they help with the clotting, but they also help with the healing after that. So there is some thought that if arthritis is an injury process, and if platelets help with healing, if we could concentrate these platelets in the serum of the blood and inject it into the joint, that it would help. And there's a variety of what are called growth factors, cytokinins, that help healing, and here's a long list of them. It's a fascinating biochemical enterprise for those interested in it. But the FDA has not approved it. There's been no real good studies to show that it's that effective. It's available. It costs around $500. We'll draw the blood, and then we have to have a fellow come in with us, brings a centrifuge. And I've tried it in several patients, and it's certainly effective in some, but not all, and it's hard to say what role it's going to play in the future. But it's not covered by Medicare, not covered by insurance. And it's been described as sort of the caffeine for the knee. Bracing, I think underutilized. A lot of people would benefit from braces. There's a variety of different braces. This one shown here, it's sort of the heavier brace, used as an unloading brace, and the little diagram over here is meant to show it's trying to improve the alignment of the joint. A lot of times with arthritis, it'll affect one side of the knee. You'll either become bow-legged or knock-kneed, what we call varus and valgus. But knock-kneed and bow-legged are probably just as good. Anyway, it has been shown to help some people. I've used it a lot in fellows in their 40s and 50s or in the trades. They have to work. They really can't be taking time off from work to have extensive surgery, and it can really prolong a person's working life. But usually more effective in a male knee that's a little more heavily muscled and with a little more length. Certainly have had women patients that have used them, and I think it's for whoever, but they just have to consider it. The problem is these are fairly expensive, over $1,000, some covered by insurance, some not. And then, so we've gone through physical therapy, medications, injections, bracing, and then surgery. So what are the surgical options? Well, arthroscopy, you often hear about scoping. What do? We clean out the torn meniscus, we remove the excess synovium, we clean the loose fragments that occur in the joint. We can do a thing called microfracture, where we actually drill holes in the bone that allows what are called stem cells to come to the surface and help heal some of the cartilage. There's even a program called ACI, autologous cartilage implantation, where we take cells out, send them to a lab in Boston, they regrow it. This is really effective just for small areas of cartilage loss. It's not effective in areas of widespread arthritis. Mosaic plasty, again, another cartilage technique. We'll go through some pictures. Then there's that subchondroplasty calcium phosphate. We're showing those areas of marrow edema on the MRI and saying they could inject this calcium phosphate to help the bone heal in that area. And there's some promise that that may be effective to help arthritic joints. Corrective osteotomy. This is something, again, it's talked about more at medical meetings than it's actually done in practice. In the late 70s, when I came out, it was very common to do these osteotomies, which basically, in simple terms, meant to break the bone and change the alignment, sort of like rotating your tires. And in those days, in the late 70s, total knee replacement was not that reliably producing good results. Things have certainly improved over those many years, and so we see very few osteotomies being done, but it still is an option, and some people will elect it. When you see a younger person who doesn't want to move toward joint replacement, it can be an option. And then joint replacement, either partial or complete. So let's just kind of briefly go through some of these things and see what questions you folks might have. The arthroscopy, we show this scene here of the roadway and a piece of tire that's come off a truck or car. And a similar thing when we use our tire analogy for cartilage inside the joint. When we're scoping the joint, we often see fragments that come loose in the joint. We can clean that out. What is the effectiveness of it? Well, there's a lot of studies that have been done following up on knee arthritis. I think the important thing for people to understand is it's not going to cure the arthritis, but for many people it's helpful. When you look at this series of studies here, this was one done. It was a 10-year follow-up, and a significant number of those patients, 2/3 of them, didn't go on to need a knee replacement. So they had arthritis 10 years later. 2/3 of them still had not had a knee replacement. Only 1/3 went on to knee replacement. Again, about 60% didn't need any additional surgery. And this is something I've seen in my own practice, that it's a fairly simple thing to do. It's outpatient surgery. Certainly wouldn't want to mislead anyone to thinking it's a cure, but it certainly can help diminish symptoms, take care of a torn meniscus, remove some of those fragments, remove some of the synovium. It can help. There were a series of papers, again, showing 2 to 4 years, anywhere from 3/4 to 2/3 of the knees were good to excellent. So what is meniscectomy? Well, this is looking down on top of the shin bone or tibia, and we were talking about the meniscus and showing you some of the anatomy. And that's what it looks like. You get tears or flaps, and we can go in there and we just clean that out. We trim those, much in the same way you might trim your fingernails if you had a piece of the nail that was torn. There's the lining we were talking about, synovium. Sometimes it overgrows, and we can remove some of that and diminish some of the swelling that occurs in the joint. We have different instruments, almost like vacuum cleaners, as you can see here. I don't know. It's sort of like looking at dental instruments. For a lot of people, it's not that appealing, but that's what goes on when we talk about this word debridement. It's basically cleaning out. These are some fragments that I took out of a knee at the time of arthroscopy, and you might say, where did they come from? Well, this is what normal cartilage looks like, white, shiny, and smooth. Here's a crater. This is a pattern I see day in and day out when I scope advanced arthritic knees. So this cartilage comes out and floats around, and we take it out. Now, that doesn't make this normal, but it does improve it. For a lot of patients, it takes away some of the inflammation. And this is also an area we could microfracture. We could drill down in there. It means an extended period, around a month on crutches. Certainly, the cartilage that regrows is not as good as the original material, but it might be better than bone on bone. So that's an option. And for limited areas, it can be effective, called microfracture. This is something I went to Sweden in '96 to learn how to do. And it's, again, has limited usefulness in arthritis. It's primarily post-traumatic type situations where someone's had an injury, lost some of the cartilage. We can patch that. It takes a couple operations to do it. One, to take the cartilage cells from a less used area, supposedly, and send it for what's called tissue culture. They regrow it, and we put a patch over it. Mosaic plasty is sort of like the hair transplant for us guys, where you take hair from, let's say, one spot and move it to another. So we're moving these plugs of bone and cartilage, and we'll move it to an area of high pressure. It can be helpful. So those are sort of the biologic approaches. Then we move into the metal and plastic unicondylar partial knee. What's that mean? Osteoarthritis is a segmental disease. There's the medial side, you might call it the big toe part, the lateral outside, and the patellofemoral. The medial side, the most common pattern of osteoarthritis I see again and again is this medial, where you get narrowing, loss of joint space. And a lot of times it gets down to bone on bone. For some people, doing a partial knee replacement is the best treatment. And it can help them avoid getting into a total knee replacement in some cases. And the longevity of these has been rivaling that of a total knee. And a well-done unicondylar knee replacement always beats a total knee replacement. This shows what we're talking about. Here's a relatively normal looking joint space. Here we get, it's narrowed 2 millimeters or less, and then we get bone on bone. These two categories in this Allback classification system would be candidates for the partial knee replacement. This obviously has gone past that stage, and the only thing that person could do is go to total knee. Sometimes described as near arthroscopic rehabilitation. I think that's a little overstated, but it certainly is a lot less than a total knee. So quicker recovery. I see a better range of motion in my unicondylar knee replacements. I see more complete pain relief and a more natural feeling joint. It addresses some of the things we've talked about, ligament imbalance. It addresses that sclerotic hard bone. It's a segmental treatment of a segmental disease, which makes sense. It preserves bone for future. If you're, we do these sometimes in total joint replacements in people that are 50 years old, and hopefully they're going to live a long, healthy life, maybe 40 years. They might, if they start with a total knee and you have to, if you have to replace that and do a revision, it's much more difficult to revise a total knee to another total knee, much easier to do a uni, a partial. So this just shows the relative frequency. And what we see here, this primary, of these 300 and some patients, 166 of those knees, it was mainly just in the medial compartment. And that's something I see all the time. So this is that partial knee replacement. And it seems a shame to sacrifice all the rest if that's the only area. So survival for these has been pretty good. You look at O'Rourke, 21 years, 86%. We see Berger, 13 years, 96. I think he's got some studies out now close to 20 years where I think it's about 93% survival. So that's very good. This is the one study was done, we call a prospective study. That means that it's not, retrospective is where you just take 100 people that have had various surgeries and you go back and compare them. Prospective means you start out and you find some way to randomize people, and they sign up for it, and they go, you'll either have a partial or you'll have a total, and we'll draw it out of a hat. And I guess they get people to sign up for it. But the study they did showed that they had 71% excellent results with the uni, 53% excellent with the total. And the survival at 15 years was better with the uni. So that goes against some of the studies we've seen previously. Total joint replacement, a very good operation. It's important, though, I think, as a patient to understand there are different types of knee replacement. There's probably some, I know as an orthopedic surgeon, if I was going to have a knee replacement, I'd probably prefer a partial over a complete. If I had to have a complete, I'd prefer a cruciate retaining, where you keep 3 of the 4 major ligaments, versus the posterior stabilized, where you keep only 2 of your 4 ligaments. And then finally the constrained, where you really have inadequate ligamentous stability, so it requires a constrained implant. Too late, too early. What's that mean? Well, studies have shown when you look at the dissatisfaction rate with total joints, one of the causes was that perhaps someone did it too soon. In other words, they certainly had a knee that bothered them. They got aggravated with it. They got it done. And in truth, they probably would have been best served by continuing with conservative, non-operative treatment or at most arthroscopy, because there wasn't adequate difference. You know, if you go into something and you've got a pain level that's very high and you bring it down to a 1 or 2 level, then you're going to be pretty satisfied. If you're at a 3 or a 4 pain level, whatever that means, and you get it down to a 1 or 2, you're going to be less satisfied. But waiting until it's too late, this is something I certainly would warn against. I see lots of patients who just develop horrendous problems with their knee. The ligaments are destroyed, the bones eroded, they've got contractures, they've got atrophy or wasting of their muscles, and then they decide, now I'm going to have a knee replacement, and they expect to have the same result as their neighbor next door who had his knee done at a much more advantageous time. What is computer-assisted surgery? This is what we use nowadays. It's very helpful. We put these diode markers on the knee. It allows us to get the alignment very accurate. And this is sort of like the global positioning systems you have on your cars. And this is what it looks like during surgery. It's just, these things look at the diode lights coming off, and the computer reconstructs the alignment for us. What are some of the things if you are going to have a knee replacement? You want to go someplace where they do a lot of them. We're fortunate here in Chicago. There are a lot of hospitals that do that. Ingalls is certainly a high volume joint center. We do a lot of joints there. We have a joint center. It's a nice campus there. And the rooms are very nice. They're all private rooms. We have a floor where there's no one with infections. And all these things are important in getting a safe journey for you as you go through a knee replacement. And you have nurses that are very experienced in dealing with these implants. So this is my last thing I'll say here before we open it up to some questions. Know where you want to go. I mean, it's important to, you can get lost thinking about subchondroplasty and meniscectomies. And I think basically when you talk to your doctor, you want to let them know what you want. I mean, do you enjoy playing golf? Do you like going to the theater? Do you want to play doubles tennis? What's the best treatment for you to allow you to meet your goals? And I think oftentimes I know patients come in and they're asking me, what should they have a knee replacement or not have a knee replacement? But it takes a while. You got to get to know the person, know what their goals are, how good a candidate they will be in terms of working at their rehab afterwards. So just think of Warren Bond here pointing to the direction he wants to go. Well, I hope that helped a little bit. We covered a lot of material. I know we went kind of fast, but I want to just kind of bring these things up for the conversation. I think it helps you at least think about what your options are.
Okay, thank you. We've got some questions that have come in. So as we go through these, if you have additional questions, please feel free to type them in. First question, can you help knees with rubbing bone against bone or ones with little cartilage?
Well, we certainly can treat them. I mean, the one thing that I have seen, let's talk about the viscosupplementation. When we started using that about 15 years ago, I would see people with bone on bone, and I would think that it was extremely unlikely we were going to help those people. But I did see that there were some patients who wanted to try it, and it was helpful. I've had patients with bone on bone that were helped by cortisone injections. We've had folks that bone on bone, and we've helped them with arthroscopy, cleaning out the joint. So any of those 5 categories we talked about could still be applied to someone with bone on bone. But it's very important to be realistic about what you can expect, no matter what we do, whether it's one of those procedures or whether it's a total knee. It's not going to give you the knee you had when you were 21. You certainly can get an amazing improvement with total joints, but we don't want to oversell the idea, and I think the best thing is to have a well-informed patient. So to answer your question, yes, there's things we can do, and it certainly, I can't say it's going to help in every case, but I think it's for a person who's committed to trying to manage, and that's the word I think I should have introduced a little sooner. It really is a management problem. If you have diabetes, if you have high blood pressure, we can't cure it, but we can help you manage it. And it can be very effective. So yes, you can manage bone on bone through any of these 5 categories. It's hard to predict which one, if any of them, will work, but it's something you need to discuss with your doctor.
Okay. Can an X-ray tell if surgery is necessary or if a person just needs therapy?
I don't want to treat X-rays. I mean, I think X-rays are important in telling us some things, but when you look at what we'd call the correlation or the predictability, in other words, if I sat in a room and you said, I'm going to give you some information, I want you to tell me, the doctor, how well the person's doing. The one thing that I would ask for is an MRI and look for bone marrow edema. That's been the thing that's been most productive of pain. The amount of cartilage on an X-ray is not always. I see many patients who come to us with arthritis in both knees. I'll look at the X-rays before I go in the room. The right knee will be bone on bone. The left knee will be arthritic, but doesn't look as bad. And I'll go in the room and go, oh, that right knee looks terrible. And they go, well, it's my left knee that hurts me. So the doctor's role, I think the original word doctor is some Latin derivative from docere that meant to teach. And that's really part of our role, particularly in arthritis, not to tell you what you need, because really no one needs a total knee. I mean, we need oxygen and water, but a total knee is an option that's right for some people. You need some education about what's involved, what are the likely outcomes, and what are the alternative treatments. I know that doesn't answer your question, and I don't doubt you can find someone who will walk in a room, point to an X-ray, and tell you you need a total knee, but I'm afraid it won't be me.
Okay. The next one is kind of 3 or 4 parts rolled together. She is looking for some suggestions for pain management, and some of the background is that she's had a ruptured colon, 3 hernia repairs, and some gastric bleeding from time to time. She is anemic and taking iron 3 times a day and is looking for something more natural. She does get some relief from Aleve. She's had a torn meniscus repair after a fall and has been getting yearly shots. It's been about 8 years. And looking for pain management.
Well, I wish I were that smart, I could tell you. Well, certainly, when I see someone who has a complex history like you have, it would take a while. We'd have to talk for a while. I mean, let's just say we went through those 5 categories briefly, and we said therapy. Well, that's a fairly safe thing for the things you've had, and I think it could help. Let's say you had lost some motion. Sometimes 3 to 5 degrees of loss of straightening of the knee can make a significant difference in your pain. And so I often start with some therapy, get you instruction in stretching exercises, strengthening exercises. So that's one thing you can do. Bracing is often neglected. I find so many patients have never tried a brace. And I often tell them to start with the stuff you get at Walgreens or the drugstore, just a light elastic support. It can be effective. And then there's some more advanced ones. We could talk about those. In terms of medications, with your history of bleeding, I think you have to be careful about the NSAIDs, the non-steroidal anti-inflammatory drugs. And certainly you'd want to talk to your internist about that, and with the GI problems you've had, the gastrointestinal problems, you'd be very careful with the pills. I think injection techniques would be very reasonable to consider, particularly what we call viscose supplementation. The one I use most often is called Orthovis. So there we've got bracing, physical therapy, Orthovis. Surgical intervention, certainly, but it sounds like you've been through a lot, and signing up for an operation right now may not be the wisest thing to do. Knee replacement is always elective, and you need to be in optimal health to have it done, and that's something we want to approach slowly. So for a person like yourself that has a complex history, it would take several visits and discussions and some trials of some safe treatments before we would venture into anything more involved than bracing, injections, and therapy.
Okay, next question. Can you give us an idea of what's involved in after surgery physical therapy?
Yes, it's there's certainly variability, but just to give you a brief idea, what I do, the average time in the hospital, after the total knee nowadays is 2 to 3 days, and there are some folks that are looking at doing them as outpatient. I'm certainly not a fan of that idea just yet. Who knows, with time we may all be suggesting that. But a couple days in the hospital. I want my patients to use a walker or crutches for 4 weeks, even though many of them could go without it sooner. I'm not a big fan of canes. What I like about the walkers, they're safe in the sense that you've got something to hang on to if you need it. You can full weight bear right after the total joint replacement. That's not the reason. It's just basically to help you proceed in a safe fashion so you're not falling. Physical therapy starts the day after surgery in the hospital and continues as an outpatient. We have 4 offices and we have 4 therapy centers, and they know our program. I would say on average it's 2 to 3 months of physical therapy, going perhaps twice a week, sometimes 3 times, depending on how you're progressing. Everyone progresses differently. Some people are very quick to get their range of motion back. For some, it's more of a struggle. So 2 days in the hospital, 4 weeks on a walker, physical therapy for 2 to 3 months.
Okay. The next one is a gentleman who has had a knee scope but still is in a lot of pain, and also had a meniscus tear. What's the next option?
Well, again, we would obviously, the thing always worries me anytime I'm giving people advice without seeing them, and you need to listen to your doctor, and I don't want to interfere with that. But let me just mention some things I see in my own practice. I certainly have scoped thousands of patients over 30 some years, and I wish I could say all of them got better, but they don't. Sometimes you can have a torn meniscus and have some other associated problem like arthritis. And then you've taken care of one problem, the torn meniscus, one potential pain generator, but others remain. And the arthritis may be the chief problem now, and for that you might need a cortisone shot. You might need a little additional therapy, maybe a brace. To answer your question more completely, I would need to really look at your MRI to see if you had bone marrow edema, to see if you have significant arthritis. But sometimes, again, if you're 20 years old and all you have is a torn meniscus, most times you're going to do pretty well. But as we get older and we have other issues other than just the torn meniscus, it's not uncommon to have some residual problems that will need treatment either with injections, pills, braces, or therapy.
Okay. I am at home alone, and what can I do after a partial knee surgery? Can I drive to and from physical therapy sessions myself?
Well, obviously, that's an important thing in terms of your ability to drive. Studies have shown, let's say if it was your right knee that you had a partial knee replacement on, the concern is not about the implant. The concern is your ability to respond from brake. If the person in front of you stops in a hurry or a child runs out in front of you, can you respond quickly going from brake to accelerator? From accelerator to brake. And the studies that have been done looking at response times after having what we would consider an arthrotomy, in other words, opening the knee, is 4 to 6 weeks. Some years ago, I broke my tibia and I was in a cast. And I actually drove with my left foot. I'm not advocating that, but I didn't see it as a real monumental feat if I was, careful, and I tried it out in a parking lot before I did anything. So the driving thing is like all of us. Each of us, if you're taking cold remedies or you're sick, you really have to, driving is a serious thing, and we could hurt some other human being, and we don't want that. So the driving has nothing to do with the implant. It has to do with your ability to respond.
Okay. All right. So this person has Humana insurance, questions about insurance, and wants to know, in order to get a consultation with you, does she need to get a referral from her doctor?
Well, I know that's an important question, but I'll be honest with you. I decided years ago that I would try and devote what intellectual abilities I have to being a doctor and try and stay out of the insurance business because it's too complicated. I don't really know. But probably if, Humana has a lot of different insurance programs, and I would assume that if you've got the policy around or if you have a primary care doctor, perhaps you could ask them. Or you certainly can call the office, and we have insurance people, and you tell them what the policy is, and they would let you know. We try and work with people as best we can, and I see everyone, Medicaid, Medicare, so it's not us, it's whether your insurance company is going to allow it.
Okay, it seems to be the last question for now, anyway, unless anybody asks others. It's multiple questions kind of rolled into one. Gentleman walks 4 miles a day and wants to know, why does it hurt only sometimes and at different intensities? Other factors, his shoes wear out at the outside heels on both feet. And why does he only have pain on the left half or left side? And then there's a follow-up question from the same gentleman, wants to know if Medicare covers all of these treatments that we've discussed tonight.
Medicare, we'll start with that one. Medicare covers almost everything I talked about except the PRP injections. Actually, Medicare's, even though it gets maligned a lot, it actually is pretty good insurance. And for most reasonable things that are approved by the FDA, Medicare will cover. Why it hurts some days and others, I'll be honest with you, I don't know exactly why. We know that barometric pressure makes a difference. But, again, for someone who's done this for 35 years, you would think I would know the answer to that, but I really don't. Just the variability of what people experience. They'll go through periods where it just seems terrible and they're ready to sign up for a total knee. And then it starts to improve a little bit. So barometric pressure changes, I guess, would be one explanation, but it's hard to say. The problem with your shoe wear is something you might help yourself a little bit with an orthotic. I think that's where physical therapy can work with you. We have them sometimes, they do some taping, this kinesiology taping like they did during the Olympics, you'll see. And then if it gives you some relief, it's a simple thing you can do. And oftentimes with just the store variety orthotics, and you can balance that out a little better. So that might help your knee to some degree. So let's see, I think we answered Medicare, covers most everything but the PRP. I don't know why it hurts some days and not the others, but that's not unusual. I don't, that's something I hear all the time. And I think did we cover that?
Yes, looks like we covered all the bases. We do have one last question that came in. My knee aches and feels warm to the touch. What can be causing this? It was replaced in 2004.
Well, certainly in the first 6 months after a total knee, they usually are warmer. When you've done, years ago they did that, those thermograms, where you take a picture and you see hot areas, and there's ways with lasers they can measure temperature. But it's a fact that total knee, I tell my patients, because a lot of people get concerned right after they've had a total knee that it's more warm. Now, how long that lasts, I'll be honest with you, I don't know the exact thing. It is possible. We're always concerned about infection, and I wouldn't want to just tell you, oh, it's fine. But if you have real concerns, there are some blood tests that you can get, fairly simple, to make sure there's no significant inflammation that could relate to an infection. It's probably worth considering. So the increased vascularity after you've had surgery in an area is not unusual. Increased vascularity means increased blood flow, which means increased warmth in that area.
Okay, thank you. The last question is just how can I be seen at Bone and Joint? And our number is on the screen. Give us a call. People are there to make appointments. And for the rest of you that have questions about insurance, the staff that's there that answer the phone, they can tell you what your policy covers and doesn't cover, and whether or not you need a referral from your primary care provider. So if that's it, we'd like to thank you all for joining us. We do these about once a month, about the middle of the month. So we've already got one scheduled for January. So as you, if you think about it and have additional questions, come see us in a month. Or if there's anybody you know that could benefit from this, we'll do it again. And thank you very much. Happy holidays, everybody.